So, in this presentation, I'm going to talk about schizophrenia. So, under the introduction section, the information we are going to talk about, so the term schizophrenia literally means split mind. So, the word schizophrenia is the schizo means split, and the phenia in this case refers to the mind. Even though schizophrenia can be interpreted to the meaning like splitting of the mind, it does not refer to a split personality, but rather schizophrenia refers to like scattered or fragmented pattern of thinking. Schizophrenia is a psychotic disorder that causes severe mental disturbances that disrupt thoughts, speech, and behavior. So it causes severe uh, mental disturbances because all those symptoms they experience hallucination delusions. I mean, they are very severe symptoms. So for different types of the psychological disorder, there are all sorts of symptoms that might be associated with it. And different people might experience different symptoms and in different severity. However, for schizophrenia, like those symptoms are more severe when compared to other psychological disorders. So most of the symptoms from any kind of psychological disorders, they can be the extreme versions of a normal psychological process. For example, everyone has the heartbeat, but people with a heart disease, they may have a fast heartbeat. So everyone has a normal body temperature, but during a fever, that temperature is higher. So for those psychotic symptoms, like such as delusion, hallucination, disorganized speech, they are on the more severe and extreme side, which cause the severe mental disturbances that disrupt the thought, speech, and the behavior. Symptoms of schizophrenia can be categorized into three major areas. So positive symptoms, negative symptoms, and the cognitive symptoms. For the positive symptoms, they are the psychotic behavior that is not generally seen in healthy people. So people with positive symptoms, they may lose touch with some aspect of the reality because the symptoms, they could be hallucinations or delusions. So the negative symptoms are associated with disruption to the normal emotions or behaviors. It could be the flat affect. So it is the reduced expression of the emotions through the facial expression of the voice. So the reduced feeling of pleasure in everyday life and difficulty beginning activities and reduced speaking. So those symptoms are very similar to people who suffer from the depression, the negative symptoms. So the last one is cognitive symptoms. For some people with the schizophrenia, the cognitive symptoms of the schizophrenia are not severe, but for others, they can be more severe. And they may notice the changes in their memories or other aspect of the thinking. So the symptoms could be the poor executive functioning, which refers to their ability to understand information and use those information to make decisions. They may also experience trouble focusing or pay attention, problems with working memories, which refers to their ability to use the information immediately after learning. So people with schizophrenia, they may seem like they have lost the touch with the reality because of symptoms such as hallucination or delusion. So they are more likely to experience difficulties in basically every aspect of their life, with their family, with their friends, the social life, occupational functioning. They are all going to decline because of the symptoms. So when we treat the schizophrenia, we want to treat those symptoms as earlier as possible so that we can limit the decline, also limit the stress, because the goal of the treatment would be mainly focused on resolving the symptoms and limiting the stress and improving the functions. So now we move on and talk about the DSM-5 and the diagnosis. So the DSM-5 outlines the following criteria to make a diagnosis of schizophrenia. So criteria A is two or more of the following for at least 1 month or longer period of time, and at least one of them must be 1, 2, or 3. So those are the symptoms that has been listed right here. Delusions is the first one, hallucinations is the second one, disorganized speech is the third one, grossly disorganized and catatonic behaviors is the fourth one, and also the negative symptoms. So in order for us to give the diagnosis, they must have one of them from the delusions, hallucinations, or disorganized speech. So basically, in order for us to give the official diagnosis of schizophrenia, they could not just have the disorganized behavior or and the negative symptoms. So they have to have at least one of the, let's say, one of the symptoms, delusions, hallucinations, or the disorganized speech. Even though some people who suffer from schizophrenia, they have the cognitive symptoms as well, they are not specifically needed for diagnosis. So when we give the diagnosis, it's very important to pay attention to the delusions, hallucinations, or disorganized speech. So delusions, they are the false beliefs that the people might feel very strongly about, so that they won't change their mind, even though you gave the evidence to against their delusions. There are all sorts of different delusions. For example, a delusion of control, where somebody thinks that some outside force or person or things is controlling their action. So I remember there is actually a movie called A Beautiful Man. So that movie was based on a famous mathematician. His name is John Nash. So John Nash, he was diagnosed with paranoid schizophrenia, in which he believed that he was being followed by some secret agent from Russia, and they wanted to kill him. So basically, they are the false beliefs that, however, he actually believed it. He thinks they are real. So those are the delusions. And also it could be like the delusions of reference, where someone might think that the insignificant remarks are directed at them, like newscaster is speaking directly to them through the TV. So the next one, let's talk about hallucinations. Hallucinations are the second type of the positive symptoms. It can be any kind of sensations that are not actually there, including the visual, but also including the auditory sensations, like hearing voices or commands. So for example, let's say uh, if I suffer from schizophrenia, I may say some ghost in my room while I'm recording this video. I may hearing some voice like God is telling me that I need to jump out from my house so that I will be free from this presentation. So anyway, so those are the hallucinations. The third symptoms is disorganized speech. So for the disorganized speech, an example could be something like a potato computer that does not make. I mean, even like when I play video games, like when I say something like I have bad computer, I may say my computer is a potato computer, but I guess this is not a good example. So another example could be, let's say, pencil dog, coffee window. So again, it's just the random words or random phrase that come out from someone's mouth. So it does not make sense to anyone. It's just the random words or random sentence that does not make sense. Disorganized behaviors, on the other hand, could be like if they exhibit the bizarre or silly behaviors that is out of context and does not seem to have much of a purpose. Like for example, wearing um, 3 jackets on a hot summer day. So also something that sometimes the behavior is described as a catatonic, which has to do with their movement and posture or the responsiveness. So they might be super resistant to moving or being in an unresponsible manner. So next one is negative symptoms, such as diminished emotional expression. So we talked about this in the first slide. The negative symptoms, they are like when there is this reduction or removal of a normal process, and this like a decrease in emotions, like they can express on those of interest in things they once found interesting. So negative symptoms can be very similar to the symptoms of depression. A third type of negative symptoms is the alienation, so which the decrease in motivation to complete certain goals. So someone might stay at home for a long period of time without trying to reach out to friends or to find work. So those are the symptoms that are included in the criteria A. So criteria B, impairment in one of the major areas of the function for a significant period of time since the onset of disturbance. So work, interpersonal relations, or self-care. So it has to cause the significant impairment in the major areas of their function. Criteria say some sign of the disorder must last for a continuous period of at least 6 months. This 6 months period must include at least 1 month of symptoms or less if treated. Then that meet criteria A is the active phase symptoms. It may include period of residual symptoms. During the residual symptoms, only negative symptoms may be present. So in the later of this presentation, we are going to talk about the different phase of schizophrenia. So for the active phase of schizophrenia, they can meet the criteria A, and during the residual phase, they are more likely to have the negative symptoms. So criteria D is schizoaffective disorder and bipolar or depressive disorder with psychotic features have been ruled out. So it just talk about the comorbidities. We have to rule out other possible diagnoses, such as a schizoaffective disorder or bipolar or depressive disorder. And criteria is no major depressive or manic episodes occur concurrent with active phase symptoms. Criteria F, if mood episodes, depressive or manic have occurred during active phase or symptoms, they have been present for a minority of the total duration of the active and residual phase of the illness. So the mood symptoms and the mood disorders are common that in the comorbidity of schizophrenia, especially like maybe concurrent with the active phase of the symptoms. However, distinct from the psychotic mood disorder, the schizophrenia disorder requires the presence of the delusion or hallucination in the absence of the mood episodes. So in addition, like the mood episodes take in total should be present for only a minority of the total duration of the active and the residual period of the illness. So this is the DSM-5 criteria and the diagnosis. So now let's move to the epidemiology. So schizophrenia is a devastating psychological disorder with a median lifetime prevalence of 5 per 1,000 in the population. So there are 5 among 1,000. So I mean, it's not that high, but still, like 5 in 1,000. Still, I mean, if we think about how severe is this disorder, it can definitely cause significant impairment for people who suffer from that. So the age at onset is typically in adolescence or earlier adulthood, with onset after the fifth decade of the life, and in childhood, both being rare. So another thing is schizophrenia seems to happen slightly more in men than women, with the onset in the mid 20s for men, but late 20s for women. And the clinic sign of the schizophrenia are often less severe. Some studies suggest that the difference might be due to like the recognition of the dopamine symptoms. So it's less severe among women when compared to men, and also the onset is different between men and women. However, there seem to be no difference among race. And also some studies suggest that there is no difference of the rate in different countries. So in any kind of countries, the rate of schizophrenia is kind of similar, like the 5 in 1,000. So the standardized mortality rate ratio of for all-cause mortality is 2.6 for patients with schizophrenia compared to the general population. So because their symptoms are delusions and hallucinations, they are more likely to commit to suicide because like all the voices, all the things they are saying impact their judgment. And also with the excess deaths, many from the suicide during the earlier phase of the disorder and later from, so when it gets to the later of schizophrenia, people normally died from the vacciner complications. So schizophrenia definitely like reduce the life expectancies because the individuals with schizophrenia like they are also more likely to experience uh, medical conditions like diabetes, metabolic syndrome, or cardiovascular disease are more common in people who suffer from schizophrenia when compared to the normal generation. So they are more likely to experience the other physical illness or problems. So now let's move to the etiology of schizophrenia. So what causes schizophrenia? Like we really don't know, and since it seems like the signs and the symptoms of schizophrenia are pretty unique to humans. I mean, it's hard for us to imagine that like uh, a, a dog or some other animals are experiencing schizophrenia. So our understanding of the cause of schizophrenia is very limited, and one reason for that is like we have a limited understanding of how the normal mental function occur that are abnormal in schizophrenia. But in this presentation, I will just briefly discuss some of the things that has been noticed about people with schizophrenia that might play some role in how the disorder develops. So basically, we don't know um, what causes the schizophrenia, just like many other psychological disorders. We still don't know. So let's talk about the genetics of schizophrenia. The family, twin, and adoption studies provide strong evidence that schizophrenia is highly heritable. So some twin studies have examined the impact of the genes and the environment factors on the development of the schizophrenia, and estimated the genetic heritability was about 81, and the shared environmental influence was only 11%. So 81% compared to 11%. So definitely, like the schizophrenia has the genetic factors. So schizophrenia definitely runs in families. However, there are many people who have schizophrenia who do not have a family member with this schizophrenia, with this disorder. Many people with one or more family members with this disorder and also do not develop schizophrenia. So again, like when we talk about those numbers, it doesn't mean like it's a possibility. Like 81% of them like can get the schizophrenia. It's just the explanation, like the genetic estimated genetic heritability to be the 81%. The genetic agriculture of schizophrenia may include multiple common variants, each of the small effect but acting together to increase the risk of developing the disease. So, I mean, from most of the research, I mean, the conclusion we can get is like many different genes may increase the risk of schizophrenia, but it's not like one single gene causes these disorders. So it is not yet possible to use the genetic information to predict how, like who developed the schizophrenia. Scientists also think that the interactions between the genes and aspects of the individual's environment are necessary for schizophrenia to develop. So, I mean, this is just the concept of the epigenetics. And when your gene and the environmental factors interact with each other, which finally cause the development of the psychological disorder. And environmental factors, which we will talk in the next slide. So because the concordance rate for the monozygotic twins only approaches 50%, genetic makeup alone is not sufficient for the development of schizophrenia. So genetic studies have suggest that there is this predisposition of schizophrenia can be inherited. There are several genes related to the development of the brain and the brain function that have been associated with the risk of the disease. So it may be that the genetic abnormalities increase the risk of the brain developing abnormalities in certain situations. So when it comes to looking for the causes of the abnormalities, we see in the structure and the like we might want to pay attention to like the structure of the brain and the function of the brain that plays an important role in the development of schizophrenia beside the genetic factors, which we will cover in the next slide. So now let's look at the environmental factors. So after we talk about the genetic factors, now we move to environmental factors. So environmental factors include the first one, intrauterine and birth or the postnatal complications. So although the family history and the environmental factors may be reviewed as separate risk factors, but there is a strong evidence that the genetic risk and the prenatal or postnatal exposure to the infection might interact with each other, and it elevate the risk of the developing schizophrenia. So the prenatal and the postnatal exposure to the infections such as like the premature birth, low birth weight, the hypoxia. So exposure to any infections during the prenatal or the postnatal period might compromise the neural development. So although the infections might have the direct effects on the fetus, it is important that we need to pay attention to that the mom's immune response to the infections, such as production of the serum antibodies, might also contribute, even more directly to the development of the brain damage to the fetus during the pregnancy. So another environmental factor is the physical stress on the mother during the pregnancy. So some studies suggest that certain kinds of physical stress on the mother during the pregnancy, such as infections during the certain period of the pregnancy period that might be critical to the development of the brain. So those physical stressors during the pregnancy may increase the risk of the schizophrenia. Um, so, I mean, right now my wife is pregnant, so the I guess the most important thing for me, I guess the one thing I keep uh, reminding myself is just um, I need to make her happy to reduce the stress on her. And also, like when we talk about the stress and the psychosocial factors, like um, how about the interpersonal relationship with all the family members maybe affect the fetus, and because the neural network of the brain continues to develop throughout the pregnancy or even after the birth, how the child can experience the interpersonal relationship within the family is also important for their development of the brain. Um, so the negative life experience during the pregnancy may have a negative impact there that in some cases cause of the schizophrenia. So poverty, so there's also an association of the schizophrenia and the poverty, but it's very poorly understood because it is unclear that if poverty could contribute to the cause of disorder, or if people and the families they are at risk for schizophrenia, they tend towards poverty due to the mental disability of the schizophrenia itself. So the last one is substance use and social factors. So the environmental stressors can trigger the emergence or recurrence of the psychotic symptoms in the vulnerable people. So for people who suffer from schizophrenia, their stressors may be primarily related to substance use, such as alcohol, marijuana, or uh, tobacco. So one major comorbidity for schizophrenia is substance use. So this can be a huge stress on them. And also there are other social factors such as becoming unemployed or leaving the home or college, breaking off romantic relationships. So there is evidence that the environmental events that can initiate the epigenetic change that could influence the gene uh, transcription and the disease onset. So the interactions between the genetic factors and environmental factors are most important here. So the protective factors are right here, like so to counteract those factors we just talked about might be like providing the social support, the coping strategies, they are very important for treating the schizophrenia. Other than the medications. So now let's look at the abnormalities in brain. So first, let's look at the picture on the left side. So um, so we just want to talk about some of the abnormalities that has been seen in the brain with people who suffer from the schizophrenia. So the first I want to mention that some brain abnormality have been observed in individuals with schizophrenia that are visible even without the microscope. Even just look at the brain with our eyes, like one of the first thing was noticed involved these fluid filled structures inside the brain. So in this picture, we can see the inside of the brain, and there are those fluid filled structures, uh, as right here, the black areas. Um, so in some individuals with the schizophrenia, these structures are larger um, when we compare to the normal population, the healthy brain. Um, there are a few medical conditions that can cause this, but it does not appear to be happening in schizophrenia. Like there does not appear to be increased pressure that pushing this fluid filled space open further than normal. Instead, what people think it represents is that the actual amount of the brain tissue, uh, if you kind of look at the whole brain tissue, that there might be a reduction in the size of all of these brain tissue, so that this fluid filled space are just a little larger than normal because there is less total tissue of the brain. So it is the idea that the individuals who suffer from schizophrenia, they have the less tissues in their brain. So going along with this idea that the size of the cerebral cortex, so people who suffer from schizophrenia, the frontal lobe appears to be somewhat thinner, um, as well as the temporal lobe. So there's less brain tissues among those areas, both the frontal lobe and the temporal lobe. So if we look at this picture on the left side, so that some areas of the cortex, the cerebral cortex covering these lobes of the brain appears to have less tissue. They appear to be very uh, suddenly thinner in certain spots, and it's been interesting to find these abnormalities in these particular areas of the brain because these areas have a lot to do with, let's say, the frontal lobe is associated with cognitive abilities, and the temporal lobe is associated with perceptual functions. So those are the abnormalities observed in individuals with schizophrenia, specifically in the frontal and temporal lobes. So there are some of the physical differences that have been seen in individuals with schizophrenia when their brain has been examined with um, fMRI or the PET scan to look at the activity in the different areas of brain. And some study have noticed that in the area of the frontal and temporal lobes, some of those same area that the structural abnormalities has been saying, one study found that people with stereotypal personality disorder shared the same genetic and cognitive abnormalities with people with chronic schizophrenia. So this appeared to be a signal that there may be abnormality on the kind of functional scan that we have currently seen. So the likely possibility is that individuals who develop the schizophrenia, something happened abnormally during the development of the brain, and these particular areas of the brain do not develop normally, leading to the disease. Also, other organs we want to talk about is the thalamus. So because thalamus it has a critical link that integrates the diverse circuits in the brain, including the incoming sensory information with higher um, cortical regions involving in the planning response strategies like the frontal lobe. So the thalamus, as part of the circuits, including the cortex and the cerebellum, has been hypothesized to play a central role in the pathology of the schizophrenia. So the thalamus includes a number of distinct nuclei that have partially different patterns of connectivity to other brain regions. For example, the pavana, which has close connections with temporal lobe structure, is reduced in individuals with schizophrenia when compared to the normal population. Also, the volume of the medial dorsal nucleus also that is associated with the prefrontal cortex is reduced in individuals with schizophrenia. So in conclusion, we see those reductions in the subcortical nucleus relying from the thalamus to the cortex seem to have the reduction in the cortical regions of the temporal and the frontal lobes, which we may hypothesize that the thalamus play an important role in the pathology of the schizophrenia. So another organs we want to talk about is striatum. So striatum has a connection to the cortex, also has been implicated in schizophrenia, in part because the dopamine is the key neurotransmitter in these regions, that striatum is a major target of the neuromedication dopamine um, antagonism. So the compensatory increases in the dopamine structures after the long-term administration are believed to account largely for the striatum volume increase that has been rather consistently reported in individuals with schizophrenia. So now going along with the striatum and the dopamine. So now we just want to talk about the dopamine hypothesis of the schizophrenia. So schizophrenia appears to involve the abnormalities in neural pathways that use dopamine as a neurotransmitter. So dopamine is an important neurotransmitter in the nervous system that communicates a lot of information between the neurons and other parts of the brain. And the networks of the neurons that use dopamine appear to influence activities in different areas of the brain. And specifically for individuals with schizophrenia, dopamine appears to play an important role in the activity of the frontal and the temporal lobes of the brain, and particularly areas of the cerebral cortex in the frontal and the temporal lobe that play a major role in many of the cognitive, emotional, and the perceptual functions that are often abnormal in schizophrenia, which support the idea that the dopamine or the abnormality of the dopamine in the brain may be playing an important role in the pathology of schizophrenia. It is a fact that a number of medications that affect dopamine neurotransmissions often improve many of the symptoms of the schizophrenia. So there are a connection of the neurons right around the brainstem that use dopamine as a neurotransmitter, so that their somas or the cell bodies are located in the areas of the brainstem that areas called the ventral tegmental areas. That is where the somas of these neurons that are going to use dopamine are located, and then their axons project on the number of areas throughout the brain to release the dopamine onto other neurons in many areas of the brain. So one way of thinking about schizophrenia, which is purely incompetent at best, but it is nice way to think about it is that the abnormal activity in the, so right here as we can see in the picture is in the mesolimbic pathway. So the overactivity of the mesolimbic pathway is associated with the positive symptoms, and the mesocortical pathway dysfunction is associated with negative symptoms. As we talk about the ventral tegmental areas, they have the connection with that. So it is the abnormal activity in the mesolimbic pathway leads to the dysfunction in part of the frontal cortex that cause many of the cognitive symptoms of schizophrenia, and the abnormal activity in parts of the limbic structures that cause many of the negative symptoms of schizophrenia. Like we talked about the negative symptoms in the previous slides, which are the decreased emotional expression or the loss of interest. And the abnormal activity in parts of the temporal cortex that might cause many positive symptoms. So it's the overactivity of the mesolimbic pathway. So in reality, however, the abnormalities that are involved appear to be far more complex than this simple idea we just covered. There's likely widespread dysfunctions of many other neural networks, and there might be multiple neurotransmitter systems throughout many different areas of the brain involved in the pathology of schizophrenia. Like there are other hypotheses we didn't cover right here. Is GABA, GABA neurotransmitters. So there are many other neural networks may play an important role in the development of the schizophrenia. So one clue about the dopamine is like the majority of the antipsychotic medications that improve schizophrenia symptoms block the dopamine receptor, which is the D2, and to reduce the dopamine level in neurons. I mean, this just suggests that maybe schizophrenia have something to do with the increased level of dopamine. So these medications, though are neither universally or completely effective and do not work for everyone with schizophrenia, I mean, which adds to the conclusion and the meaning that there are probably more to it just than the dopamine network. So now after we talked about all those genetic environmental factors may play an important role in the development of schizophrenia and also the abnormalities in the brain, that we want to talk about the subtypes of the schizophrenia. So we are going to explore some so the schizophrenia is not just a single unitary disease. Um, There we are going to explore the underlying disease that have similar behavioral symptoms that go by the same name. However, it has the different types. So right here, the first one is paranoid schizophrenia. So for paranoid schizophrenia, the primary symptoms uh, include the delusion or hallucinations. Paranoid schizophrenia is when a person experiences delusions and hearing voices that are not there while maintaining a normal intellect and emotional expression. A fusing person may experience anger, anxiety, and they may actually be indifferent or argumentative. So these people do not experience any negative symptoms, meaning that they are rarely lose their ability to talk clearly. So the next one is disorganized schizophrenia. So for disorganized schizophrenia, their primary symptoms include disorganized thinking and behavior. So the person may have incoherent and um, incoherent thoughts and speech. This can make it difficult to perform daily activities such as preparing meals and taking care of the personal hygienes or washing clothes or dishes. So people may not be able to understand what others saying, and they may be difficult to understand, and they may present inappropriate emotions such as laughing for no reasons, and they also saying things that do not make sense, and maybe they are just consumed with their own thoughts. Catatonic schizophrenia include excessive and particular motor behavior, sometimes referred to as catatonic excitement. So catatonia can also include the decreased motor activity and engagement. For example, people in a catatonic episode demonstrate a dramatic reduction in activity where the individual they cannot speak, move, or respond. Virtually all the movement are stopped. So the final one is undifferentiated schizophrenia. So undifferentiated type is a category used for individuals who do not meet the criteria for other subtype. That is, these individuals may meet the general minimal criteria for schizophrenia, but do not exhibit a pattern of symptoms that is consistent with any other type. So it may contain all of the issues I have listed with other types of schizophrenia, but not enough of the particular type of actually being labeled with a particular type. So in this slide, we are going to talk about the stages of schizophrenia. So people with schizophrenia, they seem to cycle through the three phases, typically in order: the prodromal stage, active stage, and residual stage. The first stage is called prodromal stage and refers to the year before the symptoms happen. So people in the prodromal stage of schizophrenia often isolate themselves, stay alone in their bedroom a lot, and stop spending time with their family, with their friends, and often this seem similar to other mental disorder like depression or anxiety disorder. and their school and work performance may suffer, and they may show signs of the decreased motivation and lose of interest in activity and inappropriate and the emotions. So active stage is a stage when someone is experiencing psychotic symptoms such as hallucination, delusions, or the disorganized behaviors. So they are said to be in the uh, active stage as they are experiencing the hallucination, delusions, or disorganized stage. So the final stage of schizophrenia is called the residual stage. So the features of the residual phase are similar to the prodromal stage. Individuals in this stage do not appear psychotic, but may experience some negative symptoms such as lack of emotional expression or no energy, where they might exhibit the cognitive symptoms like not being able to concentrate and being withdrawn again, and again is similar to the prodromal phase. Now let's move to the treatment. So first we're gonna talk about the medications. So treating the schizophrenia is a, I guess, huge um, assignment. So the main problem is to maintain or to maintain the daily functioning by managing those psychotic symptoms like hallucinations and delusions. So the medications mentioned here are first generations antipsychotics. So this is the older drugs, and so the second generation antipsychotics, they are the newer drugs. So I mean, most of them work by blocking a specific type of receptor called dopamine receptor D2. So the D2 antagonist. So we all know, so we can block the dopamine receptor so that it will reduce, decrease the dopamine level in the brain. So, but we are not exactly sure why blocking these receptors has been shown to help with the psychotic symptoms. We just know that they are helpful for most of people that take the medicine. So now the second generation antipsychotics are usually performed over the first generation antipsychotics because they usually have less side effects that induce the movement disorder like Parkinsonism. And the main differences between the first generation antipsychotics and second generation antipsychotics is thought to be that the second generation antipsychotics have this tendency to block the serotonin receptor, which is a 5-HT2A antagonist, other than the D2 antagonist. So this has been shown to lead to less side effects. I mean, that is not to say that there are no side effects. I mean, it is associated with higher risk of the metabolic side effects. But so the second generation antipsychotics, second generation antipsychotic medications, there's example given here is clozapine. I don't know how to pronounce this word, but again, so for those medications, depending on what stage the person is, we will try to focus on the different treatments. So let's say that someone had their first episode of the psychosis. So we want to treat it, we would say that they are in the active phase. So the active phase is the very earlier stage where the person is having their first episode of the psychosis, like the hallucination or delusion. So this includes where they are relapsing after they are not having the episode of psychosis. So the goal here is to reduce the severity of the psychotic thoughts and the behaviors. So in individuals that are having their first episode often respond better than those are relapsing. So they might be able to take lower dosage of the medications. But because everybody responds so differently to the antipsychotic medicine, um, so we need to find what will be the most adequate dosage for them. So, I mean, in this case, if we use the first generation antipsychotics, it may seem to help them with the psychotic symptoms, like the delusions or hallucinations. Those symptoms may be reduced, but they may experience uh, side effects like slow movement. So by knowing that, it would be better for them to switch to the second generation antipsychotics that tend to produce less movement side effects. So after this, so the symptoms mm, mm, would be controlled, and then so the goal here is to prevent the relapse. So in this, at this point, the psychotherapy, would be the most helpful treatment. So in also after the medication in psychotherapy, like one thing to focus is the stress reduction. So like also as well as creating the support networks of the family or friends. So emphasizing the importance of minimizing the use of the medications. Um, so even though the psychotic symptoms might be controlled, however, the psychotherapy may help them to manage uh, other difficulties they may experience in their life, such as the side effects with the medication, uh, like another version of, let's say, the sexual dysfunction. So those things may be the target. Also, a lot of times schizophrenia comes with other symptoms besides the psychosis, like depression or the manic depression. So those are the also the things we need to pay attention in psychotherapy. So another thing to pay attention when you use a medication is the relapse. So relapse is very common for people who use the medications. So the relapse is about 20% for people who use the medication. Um, and also, there are other factors might be associated with the worse outcome. So I think in the earlier uh, of this presentation, I mentioned that male tend to be have more severe symptoms than females. We don't know why, but um, that's just something we need to pay attention to. And also, an earlier onset seem to be associated with the worst outcome. So finally, a person, um, a strong family history of schizophrenia um, also tend to have a worse outcome of the treatment. Um, so And also another thing to keep in mind is the negative symptoms um, tend to be socially declining, like the flat affect tend to get worse over time. Um, Still, research don't know why the negative symptoms tend to decline or tend to get worse over time. But this is also something you need to pay attention to. So now let's talk about the psychotherapy. So the first psychotherapy is like has been found being very effective and useful is CBT, cognitive behavioral therapy. So CBT focus on the maladaptive and irrational um, cognitions. And CBT gave us the tool to identify these delusions and hopefully change them to the rational beliefs. So primarily, the therapist does this by logically disputing the idea that the delusions are not real and helping the client to develop alternative belief system. So in CBT, therapists will often use this ABC model. So when it comes to the ABC model, which refers to the A is the activating event, B is beliefs, and C is the consequences. So it talk about how our source of maladaptive cognition start with an activating event, and that is all those we can control whether we. So activating event will need to believe, and the belief can be rational or it can be irrational. As a result of those beliefs, someone will behave in a certain way. If it's a rational, irrational belief, there will be negative consequences. So we can control our beliefs to control the consequences. For example, if our clients say they may experience so they are taking the medications, right? The medications has the side effects. So taking the medication is the activating event, um, and those side effects can be unpleasant. So the beliefs they can have is the idea that the the psychiatrist or the people who prescribe the medicine are trying to kill them. So that can be their irrational beliefs. That can be their delusions, which lead to the negative consequences. They may refuse to uh, continue the treatment. So in this case, the therapist might make the logic argument that, I mean, there's no reason for the psychiatrist or the person who prescribed the medication to kill them. So use the strategies like that to challenge their beliefs to replace with more reasonable beliefs. So psychotherapy can be effective in those cases when the drugs, the medications only reduce the symptoms in the short term. Um, However, the psychotherapy can benefit them in the long run if they can learn how to challenge their irrational beliefs. Another psychotherapy treatment is family therapy. So this is based on the idea that the whole family is responsible for the management of the symptoms of schizophrenia. This seems to be linked in some level of family dysfunction. So family therapy can help to improve the home situation and in the hope of the reducing the symptoms. So now because this is the family-centered therapy, so it's not just the person, it targets the whole family and the entire family behavior to change. So one of the main aims of the family therapy is to do the psychoeducation within the family. So if the family can understand the symptoms of the schizophrenia better, so we might be understanding when their family members act in a way that they feel unusual or in a way that frustrating others. So another focus of family therapy is to reduce the conflict within the family by addressing the reasons, and that often there is a lot of stress within the family, and this can be a result of consistent caring responsibility. So stress management techniques are needed. So there are a lot of times family caretakers, they have focus on the individual who suffer from the schizophrenia and overlook their own needs. So in the family therapy, um, it's also important to help those caretakers to look at their own needs and also the communication um, styles or the interpersonal strategies, interpersonal skills is also another one to teach the family. So another important focus is to help the family to be able to maintain this positive pattern of the behavior in the future after the therapy. So reinforce, um, like if the someone with schizophrenia does a behavior which has been pre-identified as a target, this could something as simple as washing in the morning, or gave them with talk. I just help the family members to learn all kinds of strategies so they can use after the treatment. So the last one is token economy. So the token economy is a behavioral management techniques that is based on Skinner's operant conditioning. So basically, the token economy is based on the reinforcement. So if they, I guess this is the often used in like those institutions, so that if the person with schizophrenia, that if they do something good, so give them the tokens um, that they can exchange for other things. So through the reinforcement, they may learn to engage in a more healthy lifestyles. However, the token economy does not really treat the symptoms of schizophrenia. I mean, they just help them to manage the something like the poor motivations and the social withdrawing, make them easier to deal with um, the, I guess, deal with the issues in institutional settings. One criticism about this is that people with severely unresponsible individuals, they are not going to engage with this treatment. So this can create a problem where only those people with the mild symptoms, so they receive the rewards in the token economy treatment. So this is all my presentation for schizophrenia.